If a patient with chronic limb-threatening ischemia, or CLTI, walks into your emergency department tonight, your next 60 minutes of decision-making could literally determine whether they keep their leg.
It's that critical, isn't it?
Absolutely. This isn't just another diagnosis you'll encounter. It's a critical high-stakes condition that demands swift, informed decisions, often under immense pressure. Today on The Deep Dive, we're embarking on a mission to distill the most critical insights from recent guidelines and clinical wisdom, providing you, our dedicated listener and future consultant, with a robust, evidence-based understanding of CLTI.
Right.
We'll cover everything from its evolving definition and, frankly, devastating epidemiology to the intricate pathophysiology, the comprehensive diagnostic workup, including the WI-5 classification, sophisticated imaging strategies, and the initial management principles you need.
And all framed within that demanding context of your FRCS Viva and, of course, real-world clinical scenarios. It's true. The nuances of CLTI are frequently tested, not just in theory, but I think more importantly, in practical high-stakes scenarios.
Definitely.
So we're going to systematically unpack the terminology, dive deep into the underlying pathology that makes this condition so aggressive, and critically review the diagnostic and initial management strategy. Our focus today isn't just on what to do, but deeply understanding the why behind those actions. That's really the core of building truly consultant-level thinking, isn't it?
I agree. It's that why that matters.
Think of this as a structured teaching session, much like a Focus Viva, where we'll pause for reflection, highlight crucial takeaways, and ensure you internalize the key concepts necessary to excel. #1, introduction and context.
All right, let's start by unpacking the terminology itself, because this isn't merely a semantic exercise, is it? It carries profound practical and prognostic implications.
Absolutely fundamental.
For years, we discussed critical limb ischemia, or CLI. But the shift in recent guidelines has moved us towards chronic limb-threatening ischemia, CLTI. So, what was the driving force behind this change, and what does it truly signify for us in practice?
Well, that's a fundamental starting point. The term CLI, while familiar, often sort of implied an acute, maybe sudden event, which doesn't fully capture the reality of this disease process.
Right, it felt more like an endpoint.
Exactly. CLTI, on the other hand, better reflects the chronic nature of the underlying atherosclerotic process that typically leads to this severe stage. And crucially, it emphasizes the threat to the limb.
Threat. Okay.
It's a subtle but I think significant distinction. CLI often focused on a binary critical state. You were either critical or you weren't, whereas CLTI underscores an ongoing progressive condition where the limb is constantly threatened by ischemia.
So it's more of a continuous danger zone.
Precisely. It also more clearly encompasses both persistent ischemic rest pain and/or tissue loss, like ulcers or gangrene. This gives a more precise and, frankly, actionable definition for these severe presentations of peripheral artery disease. This distinction helps us communicate the gravity and the urgency more effectively, both amongst colleagues and, critically, to our patients.
So it's about better capturing the insidious progressive nature of the disease and really highlighting the jeopardy the limb is in. And when we talk about this jeopardy, the epidemiological impact is, well, it's nothing short of staggering.
It really is.
This is a global health challenge of immense and growing scale. The Global Peripheral Artery Disease Study, which gave us data from back in 2015, estimated a staggering prevalence of 237 million PA cases worldwide.
Huge number.
Huge! And to put that in perspective, that was a 17% increase in just 5 years from 2010. Now, while those specific European Society for Vascular Surgery guidelines on asymptomatic PAD and intermittent claudication are a broader discussion for another day.
Right, different focus there.
It's vital for you to remember that CLTI represents the absolute most severe and devastating end of this entire disease spectrum.
And that severity translates directly into a truly grim prognosis. These aren't just abstract numbers. They represent lives profoundly impacted. We're looking at 5-year mortality figures for CLTI patients that, quite shockingly, range from 50% to 70%.
50 to 70%. That's unbelievable.
It is. When you compare that to the 5-year mortality of many common cancers, CLTI often has a worse prognosis. That fact alone should stop us in our tracks, really.
It absolutely should.
Furthermore, for those patients who don't receive timely and effective revascularization, the major amputation rates can be as high as 40% to 50%.
40 to 50% limb loss without intervention.
Yes. These figures underscore the critical imperative for early diagnosis and aggressive management. We're not just discussing statistics here, we're discussing life and limb.
You know, one phrase that always makes me stop and think about the gravity of CLTI is that it's a cardiovascular emergency masquerading as a foot problem.
Ah, yes, that one. Very true.
It's a statement packed with meaning, and it's an FRCS pearl you'll hear repeatedly, and for good reason. Could you unpack for us why that's such a critical understanding for any trainee, and maybe what happens when we do forget that systemic link?
That's an excellent question, and it's perhaps the single most important clinical insight for CLTI. Forgetting that systemic link is precisely where we can fail our patients badly.
How so?
The statement is profoundly true because CLTI isn't just a localized issue affecting the blood vessels of the leg. It is a stark, overt manifestation of systemic atherosclerosis,
Right, the whole body.
a widespread disease affecting the entire arterial tree. The vessels in the leg are merely one segment where the disease has progressed to its most severe symptomatic form.
Okay.
Therefore, patients presenting with CLTI are, by definition, at an extremely high risk of major adverse cardiovascular events, MACE. Think myocardial infarction, stroke, or cardiovascular death, and also major adverse limb events, MALE, which include amputation or the need for repeat revascularization.
So the foot problem is just the tip of the iceberg.
Exactly. So when a patient presents with CLTI, your immediate concern isn't just the foot, it's the heart, the brain, and indeed their overall life expectancy. If you only focus on the limb and don't address the underlying systemic risk factors, diabetes, hypertension, dyslipidemia, smoking, crisids, you're treating a symptom while the underlying disease continues to progress aggressively elsewhere.
A dangerous oversight.
Hugely dangerous. This systemic involvement means you can't just be a vascular surgeon for the leg. You have to embrace the role of, well, a critical care physician, maybe a cardiologist, often a general physician, all rolled into one because of the breadth of the underlying systemic disease.
Right.
Missing this perspective means you're missing half the picture and often the more lethal half.
Okay, so if we connect all these dots,
Right.
this shift in terminology from CLI to CLTI, the stark epidemiological data, and this concept of a systemic emergency, what's the core takeaway for our listeners as they prepare for their exams and their clinical careers? What's the bottom line here?
The core takeaway, the absolute bottom line is this. CLTI represents the most severe manifestation of peripheral artery disease. It's characterized by persistent ischemic rest pain or, crucially, tissue loss. Its epidemiological burden is immense, with devastating limb loss and mortality rates that often surpass those of many cancers.
Okay.
Therefore, it absolutely requires urgent specialist assessment and intervention, ideally within 24 hours. That urgency is key.
Only 4 hours.
Yes, not only to mitigate those devastating limb consequences, but just as critically, to address the underlying systemic cardiovascular disease and reduce major adverse cardiovascular and limb events. This is a foundational concept you must grasp thoroughly. It's non-negotiable. #2, pathophysiology and natural history.
Now let's dive into the why behind the intricate underlying mechanisms of CLTI. Expert, it's far more complex than simply a blocked artery, isn't it? Many trainees initially think of CLTI purely in terms of large vessel occlusions. What are they missing in that initial assessment?
That's a crucial point, and it's where a deeper understanding really sets you apart. While large vessel atherosclerotic occlusions in the macrocirculation are undeniably the primary drivers, CLTI also involves significant microcirculatory compromise.
Microcirculation.
This isn't just an academic distinction, it's a profound clinical challenge.
Yeah.
Often, we're so focused on the big angiogram-visible blockages that we might underestimate the role of this microcirculatory dysfunction.
Right.
And that can be the real Achilles heel in wound healing, even after a technically successful macrovascular revascularization. This dual hit macro and micro leads to profoundly inadequate tissue perfusion, especially distally in the foot.
So it's a double whammy, essentially.
Exactly. The severity of the disease isn't a simple function of a single blockage. It's a complex interplay of multiple factors. We're looking at things like reduced flow velocity, the degree and the extent of stenosis, the sheer number of occlusive lesions scattered throughout the arterial tree, and the varying development and effectiveness of the patient's collateral circulation. All these factors contribute to the overall ischemic burden.
So it's not just one factor.
No. A patient might have what looks like a relatively short occlusion on an angiogram, but if their collaterals are poor or their microcirculation is heavily compromised, their limb can still be severely threatened. It's about the cumulative impact on tissue oxygenation, not just the pipe size, if you like.
That makes perfect sense. So it's not just the main highway, but also all the smaller roads and even the capillaries at the destination. Now, what's particularly important, especially for your practice as you'll see these patients frequently, are the diabetes-specific considerations.
Ah, yes, diabetes, always a challenge.
Diabetes, as we know, creates unique diagnostic and pathophysiological challenges that can really complicate the picture.
Hmm.
Could you elaborate on how diabetes impacts the vessels in CLTI?
Absolutely. Diabetes significantly alters the arterial landscape, creating distinct challenges. We need to differentiate between two main pathologies that often coexist in diabetic patients. First, there's medial sclerosis, sometimes called Munkeberg's arteriosclerosis.
Medial sclerosis.
It's this calcification of the tunica media, the middle layer of the arterial wall. This makes the vessels stiff and incompressible. Crucially, these are not atherosclerotic plaques in the intima.
That's a key distinction.
It is. Secondly, there's the more classic intimal atherosclerotic disease, where plaque forms in the intima, narrowing the lumen. While both lead to lumen narrowing, medial sclerosis has profound implications for non-invasive testing, which we'll definitely get into.
Right.
Moreover, diabetic patients frequently experience altered pain perception due to peripheral neuropathy.
The neuropathy factor.
Yes. This can dangerously mask the typical ischemic rest pain symptoms, leading to delayed presentation, sometimes not until significant tissue loss has already occurred. It might just not feel it in the same way.
So they might present much later.
Much later. You might find other sort of atypical symptoms in these patients, things like unexplained weakness, persistent numbness, or a chronic feeling of coldness in the limb. These can be easily missed if you're not specifically looking for them and correlating them with other objective findings.
So you need a high index of suspicion.
Very high. This altered pain response means we cannot solely rely on subjective symptoms in our assessment of diabetic patients. Objective measures become even more critical.
And building on that, if blood flow is so compromised both macro and microvascularly, it stands to reason that wound healing must be severely affected. When we think about the physiology of wound healing in ischemic tissue, what's happening at a cellular level that makes these wounds so notoriously difficult to manage?
Well, it's essentially a cascade of impairments. Compromised blood flow severely disrupts every single stage of the complex multi-stage process of wound healing.
Every stage.
Every stage. Think about it. Wound healing requires a robust supply of oxygen, nutrients, growth factors, immune cells to fight infection, clear debris, and build new tissue. In an ischemic limb, the delivery of all these vital components to the wound bed is drastically reduced.
Starving the wound, basically.
Exactly. This means inflammatory cells can't effectively clear bacteria, fibroblasts can't synthesize collagen efficiently, epithelial cells can't migrate to close the wound. The result: chronic non-healing ulcers and tissue necrosis become common and persistent hallmarks of CLTI.
Just stalled.
Perpetually stalled.
Right.
Without adequate perfusion, these wounds simply cannot progress through the normal healing cascade. They're left perpetually stalled, at high risk of infection, and often leading to deeper tissue destruction.
That paints a very clear, very grim picture. And if CLTI is left untreated, the natural history for both the limb and the patient as a whole is truly bleak. Could you outline just how dire the outcomes are if we fail to intervene in a timely manner?
It's imperative to reinforce the urgency here. If CLTI is left untreated, the outcomes are devastating. We're looking at a significant risk of one-year limb loss, ranging anywhere from 10% to 40%.
10 to 40% in 1 year.
Yes. That's a massive functional impact for these individuals. Even more sobering, and again highlighting the systemic nature of this disease, is the one-year mortality rate, which could be as high as 20% to 25%.
A quarter of patients dead within a year.
Potentially, yes. These figures powerfully underscore why CLTI demands immediate, effective intervention, not just to save the limb, but actually to preserve the patient's life. It's a stark reminder that this disease doesn't just threaten the limb, it severely impacts overall survival.
You've really highlighted the insidious nature of diabetes and CLTI, particularly with the vessel changes, the medial sclerosis. And it brings up a scenario I've seen trip up more than a few registrars in vivas.
I think I know where you're going with this.
A patient with a visibly ischemic foot, maybe even tissue loss, but their ABI comes back normal, or even high, say greater than 1.4. What's going on there, and how do you teach trainees to navigate that seemingly contradictory information in a viva?
That's an excellent question, and it highlights a critical viva point and a common diagnostic pitfall. The examiner might ask you directly, explain why diabetic patients can have normal ABIs despite severe ischemia.
Okay, how should they answer?
Your answer framework needs to be precise and confident. You should begin by stating the core issue: medial sclerosis. This is the calcification of the tunica media, the middle layer of the arterial wall, which we discussed earlier. This calcification makes the vessels stiff and incompressible.
Right, the stiff pipes.
Exactly. The direct consequence of this incompressibility is that when you attempt to measure the ABI using a standard cuff and Doppler, the cuff simply cannot effectively occlude the artery.
It can't squash it flat.
Precisely. This leads to falsely elevated systolic blood pressure readings at the ankle, often resulting in that paradoxical ABI value of greater than or equal to 1.4.
So it looks fine, but it's not.
It looks fine, but it can dangerously mask severe underlying ischemia, leading to a false sense of security. Therefore, and this is the crucial practical solution, you must conclude by stating that toe pressures and the toe brachial index, TBI, are significantly more reliable in these patients.
Toe pressures are key.
Absolutely key. This is because the digital arteries in the toes are much less affected by this medial calcification and generally remain compressible. Understanding this physiological nuance is paramount for avoiding critical diagnostic errors in your diabetic CLTI patients.
Okay, so to synthesize these points on pathophysiology for our listeners, the pathology of CLTI is clearly complex, encompassing both macro and microvascular dysfunction, and the stakes, as we've discussed, are incredibly high.
Precisely. CLTI pathophysiology involves not only the large vessel disease that restricts main blood flow, but also intricate microcirculatory compromise that starve the tissues at a cellular level. Diabetes introduces additional, profound diagnostic challenges due to the specific vessel calcification, medial sclerosis, and that altered pain perception from neuropathy.
Right.
Without timely and appropriate intervention that addresses both these macro and microvascular components, the prognosis for both limb salvage and overall patient survival is indeed poor. This understanding forms the bedrock of effective multidisciplinary management, #TAG3, diagnostic framework, and WIFI classification.
With that critical groundwork laid, let's pivot to the front line. How do we practically identify and characterize CLTI when a patient presents? This is where your clinical acumen really meets objective measurement, forming your essential diagnostic toolkit. What are the key history and examination pearls we need to be acutely aware of?
We begin, as always, with a meticulous clinical assessment. In the history, you're looking for several critical red flags. The most classic is persistent ischemic rest pain.
Rest pain. Tell us more about its characteristics.
This isn't just any pain. It's characteristically severe, often excruciating. It's typically worse at night when the limb is horizontal and gravity is no longer aiding perfusion.
Worse lying down.
Exactly. And crucially, patients often find relief by dependency, hanging the foot off the side of the bed or even sleeping in a chair, because gravity then assists blood flow to the distal limb.
The dangling foot sign.
Precisely. You must distinguish this carefully from neurogenic claudication, which is usually relieved by spinal flexion, maybe bending forwards, and has a variable walking distance. And also from venous claudication, which presents more as a tightness or bursting sensation, often relieved by elevation. Very different patterns.
Okay, so rest pain is key. What else in the history?
Other critical red flags include non-healing wounds. Any ulcers or wounds present for more than 2 weeks, particularly on the foot or toes that don't show signs of healing, should immediately raise suspicion for CLTI.
2 weeks is a sort of benchmark.
It's a reasonable benchmark, yes. And of course, frank tissue necrosis or gangrene demands immediate attention. This is an unequivocal sign of severe ischemia, no question there.
So the patient's story gives us our initial strong indicators. What about the physical examination? What are the key signs we're actively looking for to confirm our suspicions?
On examination, your observations can be incredibly powerful. Start with a general inspection. Look for dependent rubor, that reddy blue discoloration of the foot or toes when it's hanging down, which then blanches on elevation.
Rubor on dependency, pallor on elevation.
Classic. Also, look for pallor on elevation itself. Look for chronic ischemic changes. Absence of hair on the dorsum of the foot, nail dystrophy thickened, brittle or discolored nails, and muscle atrophy, particularly in the calf, suggesting chronic underperfusion. A simple but highly informative test is capillary refill time. A prolonged capillary refill time of greater than 15 seconds, particularly in the toes, strongly suggests impaired microcirculation.
15 seconds, okay.
Your pulse examination must be systematic and bilateral. Palpate the femoral, popliteal, posterior tibial, and dorsalis pedis pulses. Note any absence or reduction, but remember the caveats.
Always caveats.
Always. Pulse palpation can be affected by your skill as an examiner, the ambient room temperature, sometimes congenital absence of an artery, or significant foot edema, which can obscure things.
Right.
And don't forget auscultation, listening for bruits. The presence of arterial brutes in the lower abdominal quadrants or groin significantly increases the likelihood of PD. The likelihood ratio is about 5.60.
So quite a strong indicator.
Yes, it means it's over 5 times more likely that a patient with a brute in these areas has significant PD compared to a patient without one. It's a powerful bedside indicator.
That comprehensive clinical picture is vital. But for completeness, especially in an exam setting, we also need to consider the differential diagnosis. Lower limb pain can mimic PAD in many ways. What are some of the key conditions you should be thinking about to ensure you don't miss anything?
That's a hallmark of a thoughtful clinician. Absolutely. You need to rule out other causes of limb pain or pathology. Think about conditions like a Baker's cyst behind the knee causing posterior pain, a deep vein thrombosis, DVT, causing swelling and pain, or even rare but important diseases like thromboangiitis obliterans or Berger's disease, particularly in younger smokers.
No, for Gergers.
Neurological causes are frequent mimics. Spinal cord stenosis can cause neurogenic claudication, nerve root compression from a disc can radiate pain down the leg, and peripheral neuropathy itself, from diabetes or other causes, can create burning or aching sensations.
Tricky differentials.
They are. Musculoskeletal issues like hip or foot arthritis are also common confounders. And then you have more obscure differentials like chronic exertional compartment syndrome, usually in athletes, or popliteal artery entrapment syndrome. Considering this broader differential diagnosis demonstrates a well-rounded understanding in AVIVA, shows you're thinking widely.
Okay, beyond the bedside clinical assessment, expert objective hemodynamic assessment is absolutely paramount. How do we quantify this ischemia accurately, especially given those challenges we've already discussed in diabetic patients?
Right. This is where we transition from suspicion to objective confirmation and quantification. The ankle brachial index, ABI, remains a cornerstone, though with those important caveats we keep mentioning.
What are the numbers again?
A normal ABI ranges from 0.9 to 1.3. For CLTI, we typically see thresholds of less than 0.4 for rest pain and less than 0.6 for tissue loss.
Okay, 0.4 for rest pain, 0.6 for tissue loss.
Generally, yes. However, and this is a crucial point for your exam and practice, an ABI of greater than or equal to 1.4 is considered inconclusive due to those incompressible calcified arteries we discussed. This is very common in elderly patients, those with diabetes, and those with chronic kidney disease.
So ABI was 1.4 means you can't trust it.
You can't rely on it alone, no. You need further assessment. When calculating the ABI, especially for symptomatic patients or during follow-up after revascularization, the recommended method is to divide the highest systolic pressure at the ankle level, usually DP or PT, by the highest systolic arm pressure.
Highest ankle over highest arm.
For symptomatic patients, yes. If you're using ABI purely as a prognostic risk marker for cardiovascular events and death, the guidelines suggest using the lowest ankle systolic blood pressure divided by the highest arm pressure. Subtle difference, but important context.
Right, and measurement technique.
Critically important. Your measurement conditions must be precise. Use a continuous wave Doppler probe, usually 810 millihertz, with an appropriate cuff size for the limb. The patient should be supine and resting for 5-10 minutes prior to measurement.
That rest period is key.
It really is. That pre-measurement rest period is often the one step that gets rushed or overlooked in a busy clinic or ED, and without it, you can get artificially elevated pressures, masking true ischemia. It might seem minor, but it's where real diagnostic errors can begin.
Good point.
Inflate the cuff to 20 millimole Hg above signal disappearance, but don't exceed 250 millimole Hg just in case. Attention to detail here is paramount.
That attention to detail is critical, and this brings us squarely to the toe brachial index, TDI, which you previously highlighted as indispensable in certain patient groups, particularly diabetics. What are its specific parameters, and why is it so vital?
Okay, this is a crucial FRCS pearl, so really internalize this. In diabetes, toe pressures trump ABI every time.
Trump ABI every time, got it.
Digital arteries are far less affected by vessel incompressibility due to medial sclerosis, making them a much more reliable indicator of distal perfusion in these patients. A CLTI threshold for TBI is generally considered to be less than 0.3, though broadly speaking, an index lower than 0.7 is considered abnormal.
TBI, 0.3 for CLTI.
Generally, yes. Absolute toe pressures are also highly reliable, especially in diabetic patients where the ABIs can be falsely elevated. For absolute pressures, CLTI thresholds are typically less than 50 millimole Hg for rest pain and less than 30 millimole Hg for tissue loss.
Absolute pressures, 50 for pain, 30 for tissue loss.
Correct. The measurement is performed after a 10-minute rest, using either a Doppler or, more commonly now, photoplethysmography, EPG. Typically, the absolute toe pressure is 20/40 millimilli Hg lower than the corresponding ankle pressure, so don't be surprised by that difference. But it's the absolute values, particularly 30 millimilli Hg, that are really critical when tissue loss is present.
Right. Okay. Now, putting all of this together, your meticulous clinical assessment, your objective hemodynamic measurements, how do we systematically risk stratify these patients and effectively communicate that risk to our multidisciplinary team? This seems like the perfect place for the Society for Vascular Surgery SVS wound, ischemia, foot infection, or WIFI classification. It sounds like it becomes your absolute best friend here. Could you give us a deep dive into the WIFI system?
The WIFI classification is, well, it really is a game changer in CLTI management. It's a standardized, evidence-based system for risk stratification that elegantly combines three key components to give you a comprehensive prognostic picture of the limb's threat and the likelihood of limb salvage versus amputation.
So it standardizes things.
It does.
Yeah.
And this is not just academic. It directly guides urgent treatment decisions and helps communication immensely.
Okay, break it down for us, the WI and FI.
Right. The first component is the wound, W grade, which ranges from 0 to 3 based on the depth and extent of tissue loss. Grade 0 means no wound, no ulcer, no gangrene. Simple. Grade 1 is a small, shallow ulcer, typically on a toe, without exposed deep structures. Grade 2 indicates a deeper ulcer, potentially involving tendon or bone but limited in extent, or limited gangrene not involving the heel. Grade 3 signifies extensive tissue loss. Think large, deep ulcers often involving the heel, or extensive gangrene involving bone or joint, typically larger than 5 centimeters of SIRS, or extensive deep infection involving the midfoot or hindfoot. This is the most severe wound grade.
W0 to W3. Got it. What about ischemia?
Next is the ischemia I grade, also from 0 to 3. This assesses the hemodynamic severity using ABI, TBI, or absolute toe pressures, or even TCPO, transcutaneous oxygen pressure, if you have it available. Grade 0 is no ischemia, essentially normal hemodynamics. ABI 0.8, TBI 2.6, toe pressure 60 mmHg, or TCPO 60 mmHg. Grade 1 represents mild ischemia. ABI 0.6, 0.79, TBI is 0.4, 0.59, toe pressure 40-59 mmHg, or TCPO 40-59 mmHg. Grade 2 is moderate ischemia. This is where you see ABI between 0.4 and 0.59, or a TBI between 0.3 and 0.39, toe pressure 30-39 mmHg, or a TCPO between 30 and 39 mmHg. Grade 3 represents severe ischemia. Here you'll see an ABI less than 0.4, a TBI less than 0.3, absolute toe pressure less than 30 mmHg, or a TCPO less than 30 mmHg. This indicates a very high limb threat from a perfusion standpoint.
Okay, I0 to I3 based on those objective measures. And finally, foot infection.
Finally, we have the foot infection, FI grade, again from 0 to 3, based on the clinical signs of infection severity, incorporating local and systemic signs. This often uses the Infectious Diseases Society of America, IDSA, or similar criteria. Grade 0 is no infection, no signs or symptoms. Grade 1 is a mild, local infection. Typically, superficial cellulitis may be extending 2 centimeters around the wound without systemic signs. Purulence might be present. Grade 2 indicates a moderate infection. This involves deeper structures, maybe cellulitis extending 2 centimeters, lymphangitis, abscess formation, potentially osteomyelitis, but importantly, still without systemic signs of sepsis. Grade 3 signifies a severe infection with systemic inflammatory response syndrome, SRS. This means the patient is showing those classic systemic signs like fever or hypothermia, tachycardia, tachypnoea, or an abnormal white cell count, indicating a full-blown systemic response to the foot infection. This often requires urgent surgical debridement or even amputation alongside aggressive antibiotics.
That's a very clear breakdown. The real power of WIFI, as you said, seems to be its clinical correlation with amputation risk and wound healing potential. Can you give us an example of how this classification translates into predicted outcomes? Perhaps walk us through an exam scenario.
Absolutely. The beauty of WIFI is that it moves beyond just a qualitative description like bad foot to a quantitative risk assessment. High WIFI scores, for example, a combination indicating extensive wound, severe ischemia, and severe infection, maybe a W3, I3, FI3, correlate directly with a very high one-year amputation risk without effective revascularization and infection control.
So it predicts the future, essentially.
Yeah. It gives a strong prediction, yes. Let's run through an exam scenario. Imagine a 72-year-old diabetic patient presents to the emergency department. They have a 7-centimeter heel ulcer with visible exposed calcaneus. Their ABI in that limb is 0.3, the TBI is 0.2. Clinically, they have cellulitis extending up to their ankle, and they have systemic signs of sepsis, a fever of 38.5 degrees C, and a heart rate of 110 BPM. How would you score this using WIFI, and what would be your immediate concern regarding outcomes without intervention? Take a moment to think it through.
Okay. 7-centimeter heel, also exposed bone. That sounds like W3. ABI 0.3, TBI 0.2. Definitely severe ischemia, so I3. Cellulitis plus systemic signs, that's FI3, so W3, I3, FI3.
It's exactly right. You'd score this patient as a W3, extensive wound, exposed bone, I3, severe ischemia with ABI 0.4 and TBI 0.3, and FI3, severe infection with systemic inflammatory response. This patient is a W3, I3, FI3, which translates in the WII risk stratification tables to an extremely high one-year amputation risk and a very poor chance of wound healing without urgent and aggressive multidisciplinary intervention, including revascularization and infection control, likely surgical debridement too.
Wow.
This system helps you translate complex clinical findings into predicted outcomes like amputation-free survival and wound healing potential, guiding your urgency and therapeutic strategy. It provides a common language for your entire multidisciplinary team, podiatrists, infectious disease docs, surgeons, everyone.
That scenario vividly illustrates the power of WIFI. What then is our concise, exam-ready summary on this critical diagnostic tool? How should our listeners frame this for the FRCS?
Okay, exam-ready summary for WIFI. The WIFI system provides standardized, evidence-based risk stratification for CLTI patients by integrating wound severity, WU, hemodynamic status, IFI, and foot infection burden, FI. It's crucial not only for determining the urgency and appropriate type of intervention, but also for accurately predicting limb-related outcomes, such as amputation-free survival and wound healing potential. Mastering WIFI is mastering a key aspect of modern CLTI management and effective communication within your multidisciplinary team. Nail that down. #4. Imaging strategies.
Okay, once you've clinically assessed and stratified your patient with WIFI, the next indispensable step is often imaging to precisely map the extent of the disease and critically plan your intervention. But, expert, the key question for any trainee is, which imaging modality and when do you choose it? This isn't a one-size-fits-all decision, is it? Understanding the nuances here is absolutely vital.
Indeed, it's a step where judicious choice can significantly impact patient care and procedural success. Let's start with duplex ultrasound, or DUS. This is often considered your first-line screening tool, particularly for localizing disease, maybe assessing inflow, or for follow-up after intervention.
What are its main pros and cons?
Its advantages are clear. It's relatively low cost, entirely non-invasive, and involves no ionizing radiation exposure, which is always good. It's excellent for initial screening, assessing vessel patency, and identifying significant stenoses based on velocity ratios. A jump in velocity tells you there's a narrowing. You can also directly visualize plaque burden, particularly in the more accessible femoral and popliteal arteries.
Seems pretty good. What are the downsides?
It does have important limitations that you must be aware of. Firstly, it's highly operator-dependent. The quality of the study relies heavily on the sonographer's skill and experience.
Right.
It can be challenging in heavily calcified vessels, a really common issue in diabetic CLTI patients. The calcification can obscure the view of the lumen and create acoustic shadowing, making it hard to accurately assess stenosis.
Calcification is a problem.
A big problem for ultrasound sometimes. It's also less effective in obese patients due to tissue depth, and sometimes less effective for comprehensively mapping complex multi-segment disease, especially down in the infrapopliteal vessels, or visualizing vessels across joints. So while it's a great screening tool, it's often not sufficient on its own for definitive intervention planning in complex CLTI.
Okay, so duplex gives us that crucial initial assessment or follow-up capability. But for a comprehensive anatomical RAID map, our thoughts often turn to CT angiography, or CTA. What are its unique strengths, and where do we need to be particularly cautious with CTA in this specific patient population?
CTA offers rapid and comprehensive anatomical mapping. That's its major strength. Advantages include its speed, its wide availability in most major centers, and its effectiveness as an excellent planning tool for both endovascular and open surgical procedures. It provides detailed imaging of the entire vascular tree, often from the aorta right down to the foot, giving you a quick global overview of the disease burden.
Speed and availability sound good. What's the catch?
The flip side involves significant limitations, especially pertinent in CLTI patients. There's ionizing radiation exposure, which is always a consideration, particularly in younger patients or those who might require repeat studies over time.
Radiation, okay.
More critically for this cohort, there's a significant risk of contrast-induced nephropathy from the iodinated contrast agent. This is a major concern because CLTI patients often have underlying renal impairment due to their systemic atherosclerosis or diabetes. Their kidneys are already vulnerable.
The contrast kidney injury risk is high.
It can be, yes. You also have to contend with calcium blooming artifact. Heavy vessel calcification can appear larger on the CT scan than it actually is, effectively blooming out. This artifact can, unfortunately, lead to overestimation of stenosis severity and obscure the true lumen diameter.
So it can make things look worse than they are.
Exactly. And that can lead to misinterpretation, potentially guiding you to intervene on a lesion that isn't actually as hemodynamically significant as it appears on the scan.
That calcium blooming artifact can certainly be a headache. Okay, next up we have MR angiography, or MRA. MRA seems to offer some distinct advantages, particularly regarding contrast issues and soft tissue detail. Could you elaborate?
MRA has several compelling advantages, making it a powerful tool, especially for specific patient profiles. Critically, it involves no ionizing radiation. That's a big plus.
No radiation.
It provides excellent soft tissue detail. This is particularly useful for wound assessment, maybe differentiating tissue types like osteomyelitis from spondylitis, and better delineating wound margins in complex foot infections when you're planning debridement.
Better for the soft tissues.
Much better. And importantly, MRA can also be performed with non-contrast techniques, such as time of flight, TOF, or quiescent interval slice selective, QISS, MRA. This is invaluable for patients with significant renal impairment, where both iodinated contrast for CTA and potentially gadolinium-based contrast for standard MRA might be a concern, or for patients with severe allergies to iodinated contrast.
Non-contrast options are a major advantage.
Huge advantage in the right patient. However, MRA also comes with its own set of limitations. It's typically higher in cost compared to CTA and perhaps less widely available, or it takes longer to schedule.
Cost and access.
Yes. There can sometimes be an overestimation of stenosis severity, particularly in areas of turbulent flow, although techniques are improving. Critically, there are strong contraindications for magnetic resonance imaging, things like certain ferromagnetic implants, older pacemakers, though many newer devices are MRI conditional with specific protocols, and severe claustrophobia, which can make the study impossible for some patients.
Pacemakers and claustrophobia are issues.
They certainly can be. There's also the rare but serious risk of gadolinium-induced nephrogenic systemic fibrosis, NSF, in patients with severe renal impairment. Although this risk has been significantly minimized by predominantly using the newer group 2 gadolinium contrast agents, which are much safer. And a practical challenge can be assessing the lumen within existing metal stents, as the metal causes artifacts that can obscure visualization.
Stents can be hard to see through.
Sometimes, yes.
Okay, finally, we arrive at digital subtraction angiography, or DSA. This is often talked about as the gold standard for planning, particularly when intervention is anticipated. What are the key benefits and, just as importantly, the associated risks involved?
DSA holds a unique position. It provides the most detailed, high-resolution anatomical information of the entire vascular tree, allowing for exquisite road mapping. It is, for all intents and purposes, considered the gold standard for planning revascularization, especially in complex cases with multiple lesions or poor distal vessels.
The best pictures.
Arguably, yes. A significant advantage is its ability to allow for immediate therapeutic intervention. So you can perform the diagnostic angiogram, identify the lesions, and then proceed directly to angioplasty, stenting, or atherectomy in the same session. This diagnose and treat capability makes it incredibly efficient in the right circumstances.
Diagnose and treat in one go.
Exactly. However, you must carefully consider the risk-benefit assessment. It is an invasive procedure. It involves both ionizing radiation and contrast media, with associated risks such as access site complications, think hematoma, pseudoaneurysm, dissection, and, again, the risk of contrast-induced nephropathy.
Invasive radiation contrast.
Correct. For these reasons, DSA is typically reserved for cases where an intervention is already anticipated based on clinical grounds and non-invasive imaging, or where non-invasive imaging has provided an inconclusive or inadequate roadmap for planning. It's generally not used as a primary diagnostic tool anymore, unless therapeutic intervention is the very next planned step.
Expert, that's a fantastic overview of the main modalities. This brings us to an important question you need to be ready for in a VIVA setting. When would you specifically choose MRA over CTA in CLTI assessment? How should a trainee structure that answer?
That's a classic VIVA question, testing your clinical reasoning. Your structured answer should address the key decision points, highlighting MRA's advantages in specific scenarios.
Okay, what are those scenarios?
Firstly, in patients with known significant renal impairment, particularly those with an eGFR below 30, MRA, especially using non-contrast techniques like TOF or QISS, is often preferred to avoid the risk of iodinated contrast nephropathy associated with CTA. This is a primary driver in decision-making.
Renal impairment, go for MRA.
Often, yes. Secondly, for younger patients where minimizing cumulative ionizing radiation exposure is a long-term health consideration, MRA offers a radiation-free alternative.
Younger patients avoid radiation with MRA.
Correct. Thirdly, when detailed soft tissue evaluation is critical, for example, in complex diabetic foot infections where you need to clearly differentiate osteomyelitis from surrounding cellulitis, or perhaps delineate the extent of an abscess or wound margins more precisely for surgical planning. MRA offers superior soft tissue contrast compared to CTA.
Soft tissue detail needed MRA is better.
Generally, yes. And finally, if there's a documented contraindication to iodinated contrast, such as a previous severe allergic reaction, MRA, potentially non-contrast or using gadolinium if safe, becomes the safer alternative imaging choice.
Allergy to CT contrast, use MRA.
Exactly. These are not just theoretical points, they are practical considerations that directly impact patient safety and optimal management strategy. Nailing these distinctions shows good clinical judgment.
So to synthesize this section on imaging for our listeners, the choice of imaging in CLTI is clearly a nuanced decision requiring careful thought and balancing of risks and benefits.
Exactly. The choice of imaging modality in CLTI is highly patient-specific. It depends heavily on individual patient factors, such as their renal function, allergies, implanted devices, and other comorbidities. It also depends on the local expertise and availability of each specific modality in your institution, and crucially, whether immediate therapeutic intervention is anticipated. As the clinician, you need to weigh the advantages and limitations of each modality, DOS, CTA, MRA, DSA, to select the most appropriate and safest strategy for each specific patient. This demonstrates a deep understanding beyond just reciting facts about each scan. It showcases your ability to make informed, safe, and efficient decisions tailored to the individual. #Tech5. Plan framework, evidence-based decision-making.
Okay, now let's bring it all together. Once you've thoroughly diagnosed your patient using clinical assessment, hemodynamics, and WAFI, and you've got your anatomical map from imaging, how do you structure your thought process for those complex revascularization decisions? This is where the plan framework becomes absolutely critical, not just for your FRCS EVAs, but even more importantly, for providing the best, most individualized care to your patients. PLAN stands for patient, limb, and anatomic, and it provides a robust, evidence-based approach to guide your decision-making process. Expert, let's dive into the patient risk assessment. Who is this patient? Beyond just their threatened limb, how do we assess their overall fitness for intervention?
That's where every revascularization journey truly begins, with the patient as a whole person. The P's in PLAN is for patient risk assessment, which means you need to comprehensively classify the patient into broad surgical risk categories. This isn't just a formality. It fundamentally influences your choice of intervention, whether open surgery is feasible, or if endovascular is preferred, or sometimes if any intervention is too risky.
How do we categorize them broadly?
An average surgical risk patient is typically defined as someone, say, under 80 years old, with minimal significant comorbidities, perhaps well-controlled hypertension or type 2 diabetes, but no major heart or lung issues, and importantly, good functional status. They're generally active and independent.
Okay, average risk. What about high risk?
In contrast, a high surgical risk patient might be over 80 years old or have significant cardiac comorbidities like severe coronary artery disease, poor ejection fraction, or recent heart failure admission, or substantial pulmonary comorbidities like severe COPD requiring home oxygen. Often these patients also have a limited life expectancy due to their overall frailty or burden of multiple diseases. This distinction immediately flags major considerations for choosing less invasive approaches, or perhaps even focusing on best medical therapy and wound care, or in some cases, primary amputation if revascularization is deemed futile or excessively risky.
Are there tools to help quantify this risk?
Yes, absolutely. To aid this, we often rely on validated risk calculators. While the source material mentions tools like the VSQAP, Vascular Quality Initiative Risk Calculator, or perhaps PPOSSUM, Portsmouth Physiological and Operative Severity Score for the enumeration of mortality and morbidity, particularly for predicting outcomes after major open bypass surgery, the principle is important objective risk stratification.
What about specific risks, like bleeding?
That's crucial too, especially with antiplatelet and anticoagulation therapies involved. For assessing bleeding risk, a specific and highly relevant tool mentioned is the OAC3-PP bleeding score. This score identifies key predictors of major bleeding in PP patients, and importantly, CLTI itself is included as a predictor.
CLTI predicts bleeding.
Yes. likely reflecting sicker patients, more procedures, more intense antithrombotic therapy perhaps. Other predictors included previous oral anticoagulation use, age over 80 years, congestive heart failure, severe chronic kidney disease, low GFR, a prior significant bleeding event, anemia, and dementia.
So multiple factors contribute.
Indeed. And understanding these factors is crucial because the predicted one-year risk of major bleeding can vary significantly, from a relatively low 1.3% in low-risk patients according to this score, up to a concerning high of 6.4% in high-risk patients. This directly impacts your choice and intensity of antiplatelet or anticoagulant regimens after any intervention.
Big difference in bleeding risk.
Massive. Finally, with inpatient assessment, don't overlook anesthetic considerations. The choice between regional anesthesia, like spinal or epidural, versus general anesthesia has significant physiological implications for patients with different risk profiles. For a high-risk patient with severe cardiac disease, a regional block might mitigate some of the systemic hemodynamic stress associated with the general anesthetic. This needs to be a core part of your overall patient assessment and definitely part of a shared decision-making process with your anesthetic colleagues.
That's a thorough deep dive into the patient. Now, moving on to L limb severity. This is where our WIFI classification becomes directly integrated into our decision-making, right? How does WIFI guide us in terms of the urgency and potential benefit of revascularization? And how does it shift our focus from just limb salvage to maybe effective amputation prevention in some cases?
Exactly. The L in plan, limb severity, is precisely where WIFI shines as a prognosticator and a practical decision-making tool. WIFI directly guides the urgency and estimates the potential benefit of revascularization, helping you prioritize patients and understand the likely outcomes, both good and bad. It's about more than just saving a limb sometimes. It's about achieving the best functional outcome for that specific patient, which might even be a timely amputation in rare extreme cases, followed by good rehabilitation.
How does WIFI translate into urgency levels?
For patients with very low to low risk WIFI scores, perhaps stage 1 or 2, maybe a small ulcer with mild ischemia and no infection, a more conservative management approach might be initially considered. This could involve optimizing medical therapy, intensive podiatry, and local wound care. However, it's crucial to remember that CLTI inherently implies a significant and progressive limb threat, so even these low-risk patients still require very close monitoring and follow-up.
So low risk doesn't mean no risk.
Definitely not. Patients classified as moderate risk, say WIFI stage 3, perhaps a deeper ulcer or moderate ischemia, will almost certainly benefit from revascularization. The limb is clearly threatened. Intervention is indicated to promote healing and prevent progression. But it may not always demand immediate emergency intervention within hours. You might have a day or maybe 2 to optimize the patient medically, get all your imaging sorted, and plan carefully.
Okay, moderate risk needs intervention, but maybe not emergently. What about high risk?
For those in the high to very high risk categories, WIFI stage 4 or 5, which usually involves combinations of W3, I3, or FI3, urgent revascularization is typically required to have any realistic chance of achieving limb salvage. These patients have advanced tissue loss, often with exposed bone or joint, severe ischemia limiting any healing potential, and/or severe limb or life-threatening infection. Delaying intervention in these cases significantly increases the risk of major amputation and systemic sepsis. WIFI provides that evidence-based framework to clearly communicate this urgency to the team and guide your treatment strategy, whether it's primarily aiming for wound healing in a salvageable limb, or sometimes realistically moving towards amputation as the most effective way to control sepsis and achieve rehabilitation potential.
Okay, so DIFI clearly tells us how sick the limb is and guides the urgency. This naturally leads us to AN, anatomic complexity. Once we know the patient's overall risk and the limb severity, we need to understand where the disease is located and how complex it might be to fix. This brings us to anatomical classification systems like the Global Limb Anatomic Staging System, or GLASS. Expert, can you introduce us to GIs and explain its significance specifically for CLTI planning?
Right. The AM in plan stands for anatomic complexity, and this is where systems like the Global Limb Anatomic Staging System, GS, become invaluable, particularly for planning infraguinal revascularization and CLTI. GLASS is specifically designed for COPI. It provides a structured, detailed way to define lesion severity in the femoral popliteal and tibial arterial segments. This is crucial for planning your revascularization strategy endo versus open, and importantly, for predicting the likely technical success and long-term durability of your chosen intervention.
So it quantifies the anatomical challenge.
It does. It moves us beyond simply identifying blockages on an angiogram. to quantifying the burden and complexity of disease in a way that directly correlates with revascularization outcomes, especially patency.
Is it used for all PAID or specifically CLTI?
Now, a nuance from the source material. While the European guidelines on asymptomatic PI and intermittent claudication don't fully delve into GLAS specifically for IC treatment planning, it is highly relevant and widely used now for CLTI, because it provides that precise, structured approach to defining lesion severity, particularly for planning complex distal revascularization. The system implicitly assumes that any significant inflow disease, meaning disease in the aortoiliac segment, has already been assessed and ideally addressed, because successful distal revascularization absolutely hinges on having adequate blood flow coming into the thigh.
Okay, assumes inflow is sorted. How does GLAS work?
GLAS classifies lesions based on their location. Femoropopliteal versus tibial, the length of the occlusion or stenosis, the degree of calcification, and importantly, the quality of the target outflow vessel or landing zone distally. It integrates these into a final stage.
Can you give an example?
For example, GLAS stage. I would typically represent relatively simple anatomy for intervention. Perhaps a single, short, 10 to 15 centimeter, non-calcified stenosis or occlusion in the superficial femoral artery, SFA, with good runoff vessels below the knee. Something quite favorable for endovascular treatment.
Stage 1 is simpler. What about higher stages?
As you progress to higher GLAS stages, 83-4, you encounter increasingly complex scenarios. Stage 2 might involve longer lesions or moderate calcification. Stage 3 could involve multiple levels of disease, for example, SFA and tibial, long chronic total occlusions, CTOs, heavy calcification, or poor quality runoff vessels. Stage 4 represents the most complex anatomy, perhaps very long CTOs involving multiple segments, extreme calcification, and only a single diseased tibial vessel remaining for bypass or angioplasty.
So complexity increases significantly.
Significantly. And this anatomical complexity, as defined by GLAS, directly influences both the technical feasibility and, critically, the expected long-term durability or patency of your revascularization efforts. Whether you're considering an endovascular approach like angioplasty, stenting, atherectomy, or an open surgical bypass.
How does it influence the choice?
Well, a GLAS stage IA lesion might be very amenable to a relatively simple balloon angioplasty or maybe a short stent with excellent predicted long-term patency. However, a high GLAS stage, say stage 3 or 4, often means you're looking at more complex advanced endovascular techniques like CTO crossing devices, drug-coated balloons, covered stents, perhaps needing a hybrid approach combining endo and open techniques, or maybe concluding that a complex distal bypass operation is the best or only option, provided the patient is fit enough, linking back to the P, and has suitable vein conduit available. It helps you anticipate the technical challenges and set realistic expectations for success and durability, both for yourself and, importantly, for the patient. It's all about optimizing patient selection for the best possible, most durable outcome.
If we connect this to the bigger picture expert, the plan framework seems to force a truly holistic evaluation. It makes you systematically consider the patient's overall condition, the severity of their limbs threat using WIFI, and then the specific anatomical feasibility and challenges of revascularization using something like GLAS.
Precisely. That's exactly its purpose. The plan framework provides a structured, comprehensive approach for evidence-based decision-making in CLTI management. It ensures you integrate a thorough patient risk assessment, detailed limb severity stratification using WIFI, and a sophisticated understanding of anatomic complexity, for example, using GLAS for the infrainguinal segment. This holistic approach is absolutely essential for guiding revascularization decisions, optimizing patient selection for the right procedure, and ultimately improving both limb-related and overall patient outcomes. In Aviva, articulating your thought process clearly using the plan framework demonstrates a deep, integrated consultant-level understanding of CLTI management. #DrGaro.
So what does this all mean? We've covered a tremendous amount of ground today, haven't we? From the urgent and critical definition of CLTI, its stark epidemiology and complex pathophysiology, all the way through to the systematic approach to diagnosis using advanced classifications like WIFI, the nuances of imaging choices, and the initial treatment planning guided by the comprehensive plan framework. It's a lot to take in, but each piece is vital to your development as a vascular surgeon.
Indeed, it's a dense topic, but absolutely core business for us. And I sincerely hope this deep dive has given you, our listeners, a clearer roadmap for navigating these complex CLTI cases when you encounter them, which you certainly will.
I hope so, too.
Because the ability to articulate not just the facts, but their clinical relevance, and most importantly, the rationale behind your decisions, That's truly what sets a high-performing registrar apart as they transition towards consultancy. You're not just memorizing guidelines, you're understanding how to apply this knowledge critically and strategically to individual patients.
Well said. Now here's a final thought for you to mull over as you continue your journey and prepare for your exams. Despite all the advanced classifications and guidelines we've discussed today, WIFI, GLAS, etc., our source material and indeed clinical practice highlights an ongoing challenge.
What's that?
It's the difficulty in developing a single, common anatomical classification system that comprehensively covers all stages of peripheral artery disease, from asymptomatic through claudication to CLTI, and integrates inflow, outflow, and tibial disease effectively in one system. We have systems like TAS2 for aortoiliac and femoropopliteal disease, often criticized now as outdated for guiding modern endovascular treatment planning. And we have GLAS, which is excellent for CLTI infrainguinal planning, but specifically assumes inflow disease is already addressed.
That's a very fair point. We lack that unified system.
Exactly. So the question to ponder is, what are the implications of this ongoing challenge, this lack of a single, universally accepted, comprehensive anatomical staging system for tailoring revascularization strategies consistently, not just for CLTI, but across the entire spectrum of PAD? Especially when considering the diverse patient populations we serve, with their unique anatomical variations, differing comorbidities, and even socioeconomic factors that impact presentation timing and access to advanced care. It's a complex problem that we, as vascular specialists, continue to grapple with daily. It impacts research design, comparing outcomes between centers, clinical trial enrollment, and ultimately perhaps ensuring equitable and optimal patient outcomes everywhere.
That's a really thought-provoking question.
Sure.
How do we best standardize our descriptions and decision-making across the board, something we're still working on?
It is indeed. That's a provocative question to consider as you encounter future patients and prepare for your exams. Thank you for joining us on The Deep Dive.